Hello, my name's Dr. Nicole Shears and I'm a respiratory physiotherapist and a research fellow from Melbourne in Australia. I'd like to thank Briaz for inviting me to present this webinar on the use of lung volume recruitment in people with neuromuscular disease. And in this session, I'll be discussing what lung volume recruitment, or LVR, is, when it might be indicated, and how to use LVR in clinical practice. So if we start with the taxonomy that we developed at the European Neuromuscular Centre workshop on airway clearance in people with neuromuscular disease, you'll see that we have lung volume recruitment with a bag listed as one method in our toolbox for assisting inspiration. But all these assisted inspiration methods are ways to perform lung volume recruitment. So whilst I'm going to be focusing on LVR with a bag in this talk, the principles will apply to other methods. So as a clinician, you can use the tools that you have at your disposal. One advantage of lung volume recruitment with a bag is its simplicity. So it uses readily available equipment that's not expensive compared to a non-invasive ventilator, an inspiratory positive pressure breathing device, or a mechanical insufflation-exsufflation machine. It's very portable, and it's also a really great robust backup option to a mechanical device or where mechanical devices aren't available. You can use a special LVR kit, as I'm doing in this photo over here, or you can piece together a device yourself using an ambu bag or a resuscitation bag. You'll also need a mouthpiece or a mask, with or without a one-way valve. And in addition to this equipment, I always recommend using a manometer to measure the peak inflation pressure. Some resuscitation bags have a pressure release or a pop-off valve, and this opens when airway pressures are delivered to the lungs, which can minimise the risk of barotrauma. But a pop-off valve set to, say, 35 or 40 centimetres of water may also limit the amount of air you can stack, so you just need to bear that in mind. With LVR, the concept is that you assist inspiration by taking multiple breaths in without breathing out, with the end result being a deep breath that's larger than what you could do by yourself. Now, a word about terminology. Lung volume recruitment is also known as breath stacking or air stacking. And these latter names can also be used to describe unassisted breath stacking using spontaneous deep breaths. For example, I can stack my breaths on top of each other by taking a breath in, breath in, breath in, all the way up to the top. So given the ambiguity in language, it's important to be clear on your method when we're talking about LVR. The LVR technique is nicely illustrated when we look at the flow, volume and pressure signals at the mouth. And these were obtained with a pneumatachograph as we were doing these manoeuvres. And you'll see that they're graphed against time on the x-axis across here. If we concentrate on the volume channel, you'll see first of all that we have tidal volume breathing, and then the person's taking their deepest breath in all the way up to their inspiratory capacity, and then all the way out, breathing out down to residual volume. And in this case, it's giving a vital capacity of 1.79 litres in this person with motor neurone disease. Now, this is the same person using lung volume recruitment. And again, we've got tidal volume breathing. Then we're delivering insufflations, so consecutive squeezes of the bag, breathing in without breathing out, all the way up into the person's maximum tolerable inflation point is reached. And from there, they're then instructed to breathe all the way out again down to residual volume. And we can measure this exhaled volume, and I liken it to an assisted vital capacity. And you can appreciate that during LVR, this person can inflate an additional 750 mils above their own spontaneous deepest breath. And so their spontaneous vital capacity was 40% of predicted normal, whereas in this case with LVR, they can get up above 60% of predicted. When using a one-way valve, as is the case here, the valve presents air escaping as long as the person can maintain a seal either with their lips around the mouthpiece or using a mask. And the beauty of this is that you don't need to be able to control your vocal cords to stack in this way. When we use a one-way valve, we call this exhaled volume lung insufflation capacity. You can also stack using a bag without a one-way valve. However, in that case, you need glottic control to be able to trap the air in the lungs between each of those consecutive insufflations. And using that particular method, we call the maximum inflation capacity the maximum insufflation capacity, or MIC. And this difference in the technique may be important in a person with bulbar impairment, where using a one-way valve may be more effective. There are some possible side effects to be aware of, and I want to stress that these are common across pretty much all positive pressure therapies. They are not unique to lung volume recruitment. So because we are increasing intrathoracic pressure during the manoeuvre, you get a transient reduction in venous return, and you can reduce your blood pressure momentarily. We can also get transient hyperventilation if we're not allowing people enough rest periods in between their lung volume recruitment manoeuvres. Some people may complain of abdominal bloating or distension due to swallowing air, something known as aerophagia. And because this therapy is designed to expand the chest wall, sometimes people might report a bit of chest wall or muscle soreness as well. However, one of the most rare, thankfully, but also most serious side effects to be aware of is a pneumothorax. As you can see in this chest x-ray here, this person has got a pneumothorax around here. And so one of the ways we can mitigate this is with very careful instructions, repeatedly reviewing somebody's technique over time, and also by measuring that peak inflation pressure with a manometer. So what are the indications for lung volume recruitment? Based on first principles, it can be used to improve somebody's cough, clear their sputum, reinflate the lung, for example, after a respiratory tract infection, and also as a hyperinflation exercise. So I'm going to be providing an overview of this evidence base, and the details of which are all in a narrative review that we published last year. So there have been many studies now that have shown how lung volume improvement improves peak cough flow during the manoeuvre. And this is in paediatric and adult slowly progressive neuromuscular diseases, as well as in rapidly progressive motor neurone disease or amyotrophic lateral sclerosis. Here we've got some data from Michel Toussaint, who looked at 179 people with slowly progressive diseases and showed that LVR can increase peak cough flow compared to baseline. And combining it with a manual assessed cough had the most benefit. And these kind of findings have been replicated by many other authors, as you can see I've got listed there. In people with motor neurone disease, Stuart Cleary and his colleagues showed how lung volume recruitment can increase the flow rates, not just during a cough, but also during forced expiration, such as huffing, throat clearing, and also coughing after a swallow manoeuvre. So this suggests that there may be a role for lung volume recruitment in airway protection, and this is a space that more research is currently being conducted in. And I really like this video from Doug McKim and the CanVent group, which I'd encourage you all to have a look at and watch, because it's a fantastic example of how lung volume recruitment can be used practically to help somebody blow their nose. So why does increasing inspiratory volume improve cough? So if we look at this flow volume loop, where the solid line here is a person with neuromuscular disease and respiratory muscle weakness, you can see that they've got a reduced inspiratory volume, and their peak expiratory flow is also reduced. Now, by increasing the inspiratory volume towards what you might see in a healthy person, which is this dotted line, you can see that not only do you increase inspiratory volume, but also expiratory volume and peak expiratory flow up here. And one of the factors in this is the greater elastic recoil. And so over on the right here, we've got the classic pressure volume curve where the solid line is total respiratory system compliance, and these dotted lines are chest wall and lung compliance. And you'll see that at a higher volume, means we get a greater recoil pressure, which increases expiratory airflow and therefore creates that expiratory flow bias for mucus clearance towards the mouth. So clinically, LVR is used in people who have respiratory muscle weakness and a daily sputum load or during a chest infection. It's advantageous because it is low cost, so people can have a device at home and start therapy at the first signs of symptoms. But it's worth noting that whilst LVR is used in this manner, there are very few studies that have measured the effect of lung volume recruitment on sputum removal. So there have been some studies looking at the short-term effects of lung volume recruitment, but these are all in people when they're stable. And they showed conflicting findings. So some improved vital capacity and peak cough load, whereas others didn't. And moreover, any change that was noted, which was small, were not prolonged. So we are inferring that the increase in peak cough flow that we see with cough augmentation and lung volume recruitment translates to better mucus expectoration, but we don't actually have the source data to prove this. Michelle Chatwin and Jesus Sancho have both shown that mechanical insufflation-exsufflation, so a cough assist machine, is effective in clearing secretions during acute respiratory tract infections. However, no study has looked at the effectiveness of LVR using a bag to directly clear sputum to date. Probably the main reason clinicians prescribe LVR, though, is for hyperinflation. And so very recently, this study was published that examined reasons for prescribing airway clearance and lung volume recruitment techniques in the French paediatric NIV network. And whilst they actually didn't ask about LVR using a bag, the predominant reason for prescribing assisted inflation therapy in the form of inspiratory positive pressure breathing device, so a mechanical inflation, was for thoracic mobilising. And the rationale here is that people with slowly progressive neuromuscular diseases have reduced respiratory system compliance, and therefore they develop stiff chest walls over time. And it's thought that LVR could act like a range of movement exercise and slow this decline in respiratory function in the face of progressive respiratory muscle weakness. And this is certainly why LVR is recommended in clinical care guidelines. And so not all of them, but I'll pop some of them up here. We've got the 2018 Burnkrandt Duchenne muscular dystrophy guidelines that recommend lung volume recruitment once forced vital capacity is less than 60% of predicted normal. The more recent American College of Chest Physician guidelines for people with neuromuscular disease recommend regular lung volume recruitment for patients with neuromuscular disease and reduced lung function or cough effectiveness. And then the latest UK respiratory care recommendations for people with Duchenne muscular dystrophy were put out last year, and they recommend consideration of airway clearance techniques when peak cough flow is less than 270 litres per minute. But they also stress that decisions are complex and depend on many factors. And so what we're seeing in these more recent guidelines is a shift away from starting therapy based on a threshold of some sort and more towards individualised approach, considering what your local resources might be, local expertise, and most importantly, shared decision making with the person living with the condition. So the guidelines are based on consensus opinion and data from retrospective case studies or prospective uncontrolled trials. But there have been 3 randomised controlled trials of regular hyperinflation versus a control arm published after the preparation of these guidelines. And interestingly and unfortunately, these data do not quite support the clinical rationale for doing regular LVR. So the first of these was Hemant Sornani's study, which used a mechanical insufflation-exsufflation device to provide mechanical inflation twice daily for 12 months in children with neuromuscular disease. Sherry Katz's trial was in paediatric Duchenne muscular dystrophy using a lung volume recruitment kit, which was performed twice daily for 2 years. And our own RCT involved twice daily lung volume recruitment using a kit in adults for 3 months. And the findings were all pretty consistent across these 3 randomised controlled trials, where we found no measurable improvement in vital capacity at the trial's endpoint. And adherence to the therapy in all of the studies was around about the 40 to 50% mark. Now, in Sherry Katz's trial, the median forced vital capacity of participants was around 85% of predicted. So it's possible that LVR was implemented too early. And in our study, forced vital capacity was approximately 40% of predicted, and 80% of people were already using nocturnal NIV at least. So perhaps we instigated LVR too late. So there might be that there's a sweet spot for initiating LVR if the aim is to improve respiratory system compliance and slow respiratory decline. But at the current moment, the available randomised controlled trials in the populations that they studied would suggest that there hasn't been this improvement in respiratory mechanics with lung volume recruitment therapy. What we did show, however, was that regular lung volume recruitment does improve inflation capacity or lung insufflation capacity or maximal insufflation capacity. And in our study, this occurred after the first month, which suggests a training effect in that the person got used to inflating to higher volumes. There was no dose response like you would expect if the treatment was having a cumulative benefit. And when we measured respiratory system compliance, we didn't see any change in this after the 3 months of therapy. Now, it is plausible that a longer treatment period is needed, given our group had been living with neuromuscular disease for decades. But what I think these data show is that regular LVR means you are more practiced at doing it, so that you can pick it up and use it when you start to get sick, or to help you cough, or even to blow your nose. Sherry Katz also did a qualitative sub-study within her randomised controlled trial, and these data also suggest that there's a learning curve. You know, it takes time to use LVR despite it being an easy technique. So with that overview of the evidence in mind, how can clinicians tailor lung volume recruitment to these different clinical indications? And it's really the same technique, just applied at different dosages to get at cough augmentation versus airway clearance versus hyperinflation. What we do is with a bagging circuit, and this diagram shows we've got an individualised number of compressions that you stack up until you get to that person's maximum tolerable insufflation capacity. They can exhale to residual volume if we want to measure that lung insufflation capacity, or you can just ask them to exhale to functional residual capacity. Just breathe out passively. And that's usually how we would do this technique if we're using it as a breathing exercise. You can also ask people to cough from that very top point. So you can do your maximum, so you can do your bag compressions all the way up to that maximum point again. And then instead of breathing out, holding that and coughing out. And that's how we use lung volume recruitment for cough augmentation. We can then combine the number of repetitions of those maximal inflations in order to target which of these rationale we're trying to get to. So if we're using it for cough augmentation, as I said, we might just stack up, hold that full inflation volume, and then cough out. If there's mucus is being a bit stubborn, a bit difficult to shift, we might combine that with a couple of repetitions of maximal inflations first to get air distal to the mucus and to promote that cephalad movement of secretions up towards the upper airway, where then you might be able to expectorate it more easily with a lung volume recruitment assisted cough. If we are using lung volume recruitment as an alveolar expansion exercise and to prevent respiratory tract infections, then we'd normally modify that dosage so that we are getting multiple repetitions of maximal inflations and multiple sets. Now, if someone has a chest infection though, they may be more short of breath. So you would then consider fewer repetitions per set and longer rest periods between the sets. And so you can see this, the schematic that I've put up here is kind of a typical dosage that we might do for prevention of respiratory tract infection, or it might also be something like this is how we perform it for a range of movement exercise. And so you'll note that these little circles are suggesting that this person is doing 4 compressions to get to 1 maximal inflation. They're then having a slight pause, they're repeating that. In this case, they're taking 5 of these maximal inflations with pauses in between each of them to do 1 set of therapy. You would then encourage longer rest periods between these sets, but then you would repeat those cycles over and over. So in our trial of regular lung volume recruitment, people ended up doing 5 maximal inflations or 5 very deep breaths in 5 sets. So a total of 25 big breaths each therapy session. And we asked people to perform this twice a day. So if we do a practical demonstration now, this is my LVR kit. It has a one-way valve and I'm using a mouthpiece. As I said earlier, I like to use a manometer when I'm training somebody so that we can check the inspiratory pressure. And so we do that just by taking a digital manometer and you can pop that in line anywhere. I tend to use that valve so that then now when I am doing my lung volume recruitment, you can actually get an idea of what the peak inflation pressure is. I'm going to take that out for a moment just because I don't have 2 sets of hands today. And so what I'm going to be doing is showing you how we might go about doing those compressions to get to maximal inflation capacity. The first time around, I'm going to just exhale to my functional residual capacity. So this will be how you kind of get somebody to do just a nice deep breath, assisted deep breath. So I'm going to pop the nose clip on and then stack. So that's an example of one maximal inflation. Now, if I wanted to measure that to do my lung insufflation capacity, my instructions would be to the person to then exhale all the way down to their residual volume through a spirometer, of course. So minus the spirometer today, but I will demonstrate again, stacking all the way up and then exhaling all the way down to residual volume, as if we were measuring what their lung insufflation capacity was. So you get somebody, as you would with a normal vital capacity, get them to exhale until they're completely empty. And the final thing I was going to demonstrate was how you might use lung volume recruitment for cough augmentation. So this time around, I'm going to stack myself up, but then instead of exhaling just to normal, I'm going to actually cough from that inflated position. The view here is that we get that greater inspiratory volume, more cough expiratory volume is possible, and of course greater elastic recoil to then help with the expiratory airflow. So nose peg on. And just like you might measure peak cough flow, you can also do that same manoeuvre measuring what their assisted or lung volume recruitment assisted peak cough flow is. So that's some examples of how we can use the lung volume recruitment technique to either take that nice deep breath, which we call that maximal inflation repetition, or we can use it to augment cough. And I also showed how we can measure that lung insufflation capacity from that lung volume recruitment maximal tolerable inflation point. So in summary, lung volume recruitment is a great tool for helping people take a deep breath in and improving their cough. Clinically, we suggest people have it at home if they have sputum or if they're prone to developing chest infections, because it can be a really useful early part of their action plan to escalate care in the community if they feel that they've got a bit of an infection coming on. We would also recommend that people use it a couple of times a week to stay comfortable with that technique. And then there's that conversation with individuals about whether or not they might wish to do daily lung volume recruitment for hyperinflation, bearing in mind that the randomised controlled trials so far in the populations that were studied don't necessarily have strong data to support that indication. However, there might be this sweet spot for initiating lung volume recruitment, and where that is in somebody's respiratory function, we don't know yet. There are also additional benefits that people report, such as it improves their voice. It means that they can project louder when they then go out in the evening. And it can also give people a sense of empowerment in the context of them having a fatal progressive condition. But lung volume recruitment can be a burden, and many people choose not to do it, even in a clinical trial scenario. And so I think the point is around a very open conversation and that shared decision making. So there may be that little physical harm, there may be a sweet spot where it does have long-term clinical benefit, but it's really about whether or not daily therapy, daily exercise is something that the person living with the condition wishes to incorporate into their overall care routine, knowing a lot of the other care elements that people living with severe neuromuscular disease have. And at that point, I'd like to thank Briaz again for the invitation to speak about lung volume recruitment, and thank you for listening.